Telemonitoring, its effect on hospital admission rates for adult patients with heart failure, by Louise Medearis, Doctor of Nursing candidate. Committee members, Dr. Mikkel Elby, Dr. Rita Wunderlich, and Tammy Oyer. Introduction. What is heart failure? Heart failure is the failure of the heart to effectively pump an adequate amount of blood and oxygen to meet the body's demands. It affects more than 6 million people living in the United States. Many heart failure patients seem to endure a barrage of unpleasant symptoms and interventions. Heart failure patients often require close monitoring and regimen adjustments to maintain health. Heart failure patients also tend to have a poor quality of life. In 2012, heart failure expenditures in the United States totaled almost $31 billion. In the same year, to improve the quality of healthcare, the Centers for Medicare and Medicaid Services initiated a program that reduced payments to hospitals for what they deemed as excessive readmissions for certain diagnoses. Heart failure is one of those diagnoses. The program seemed to affect the revenue for healthcare organizations significantly. More than 2,000 hospitals accumulated a total of $428 million in readmission penalties in the third year of the program. Telemonitoring seemed to be the answer to solving the admission rate issue while improving healthcare for heart failure patients. However, what exactly is telemonitoring? Telemonitoring promotes long-distance care, education, and the provision of public health services by incorporating the use of technologies such as the internet, landline communication, wireless communications, streaming processes, video conferences, and recorded images. A landmark study published in 2006 produced evidence that telemonitoring could improve healthcare outcomes for heart failure patients and indicated that further studies were needed. A literature review revealed that studies regarding telemonitoring for heart failure patients produced mixed results. Since that time, advancements in technology have grown tremendously. Patients' familiarity with electronic devices has also evolved. Background. This study was an evaluation of a large Midwestern health center's telemonitoring program. Why? To determine if telemonitoring was an appropriate intervention for decreasing hospital readmissions for heart failure patients. Also, the study launched a telemonitoring department approximately 7 years ago, and an evaluation of the telemonitoring department had never occurred. The telemonitoring program offers in-home monitoring of heart rate, blood pressure, weight, pulse oximetry, and symptoms of patients within the program. The telemonitoring department is staffed by nurses who monitor patients' vital signs between 8 a.m. to 4:30 p.m. 7 days a week. Any abnormal readings alert the nurse to review the patient's chart, call the patient for an assessment, provide education interventions, and contact the patient's healthcare provider for orders if deemed necessary. Significance to nursing. More and more people are entering the healthcare system due to heart failure. By the year 2030, the predicted expenditures related to heart failure are to be a shocking $70 billion. This is due in part to the aging baby boomers. This aging population poses a problem to nursing as there is a well-known nursing shortage. The combination of a declining number of nurses entering the workforce and the rise in the number of the nurses exiting the workforce increases the likelihood of an ineffective healthcare system. Even in the face of dwindling numbers in the nursing workforce, nurses can provide close monitoring and quality care by using telemonitoring services while decreasing healthcare costs and healthcare utilization. The framework chosen for this project is based on Dorothea Orum's self-care deficit theory. Explaining Orum's ideas on self-care might help to convey why this theory was selected. Orum believed that patients heal better when encouraged to be independent. The theory of self-care specifies that patients do not appropriately heal when relying totally on others for the care that they need. That is, they heal faster when they can provide care for themselves. When patients cannot meet their self-care requirements, they are believed to have what Orum refers to as a self-care deficit. Orm self-care deficit theory is a description of systems initiated by nursing to assist those in need to prevent self-care limitations. One could conclude that heart failure patients seem to encounter a self-care deficit as evidenced by numerous hospital readmissions associated with the disease. Orm's theory is linked to telemonitoring by allowing nurses to improve self-care for heart failure patients in the home by monitoring and intervening when their usual level of independence is altered. The PICO question for this study is, for patients recently discharged from a hospital located in the Midwest region of the United States for the treatment of heart failure, does telemonitoring plus usual care decrease hospital readmission rates in the number of readmissions over an 8-week period post-hospital discharge compared to patients receiving usual care only? Methods. The project was a quantitative exploratory design which incorporated a retrospective chart review of patients discharged from the hospital after treatment for heart failure between January 1st, 2017 through December 31st, 2019. Individual patient charts were accessed via the hospital's electronic medical records system. Data collection sheets were utilized to record the de-identified data collected for this study. Here are the data collection sheets. A convenient sample featuring 2 lists was provided to the researcher by the regional data analyst employed with the hospital located in the Midwest region of the United States. The first list was of patients treated for heart failure and discharged from the hospital between January 1st, 2017 through December 31st, 2019 to receive usual care plus telemonitoring. The second list was of patients treated for heart failure and discharged from the hospital between January 1st, 2017 and December 31st, 2019 to receive usual care only. Inclusion and exclusion criteria were examined and participants were collected accordingly. The inclusion criteria were as follows. The participants were 18 years or older. The participants were under the age of 90. The EMR had documentation of the patients having an admitting diagnosis of heart failure, a discharge diagnosis of heart failure, or a hospital admission with a diagnosis of shortness of breath, cough, edema, dyspnea, or dyspnea on exertion with reference to current heart failure decompensation as evidenced by lab work or echocardiography. The EMR had documentation that the patient was admitted to the large Midwestern organization between January 1st, 2017 through December 31st, 2019. The EMR had documentation of whether usual outpatient care or usual outpatient care plus telemonitoring was ordered. The EMR indicated hospital readmission or lack of hospital readmission 30 days after the initial hospital admission. Finally, the EMR indicated whether the patient was admitted to the hospital during an 8-week period post-discharge. The exclusion criteria were as follows. If the patient was less than 18 years of age, the EMR was closed and no data was retrieved. If the patient was 90 years of age or older. If the EMR had no documentation of the patient having an admitting diagnosis of heart failure, a discharge diagnosis of heart failure, or a hospital admission with a diagnosis of shortness of breath, cough, edema, dyspnea, or dyspnea on exertion with reference to current heart failure decompensation as evidenced by lab work or echocardiography, the EMR was closed and no data was retrieved. If the EMR had no documentation that the patient was admitted for the treatment of heart failure between January 1st, 2017 through December 31st, 2019, the EMR was closed. If the patient had dementia or evidence of other cognitive defects, the EMR was closed and no data was retrieved. If the patient was on hospice or the patient's life expectancy was documented as under 12 months between January 1st, 2017 through December 31st, 2019, the EMR was closed. If the patient was a resident of a long-term nursing facility, or if the patient's EMR had documentation that the patient was receiving home health services, the EMR was closed and no data was retrieved. Methods continued. The data collection sheets were utilized to record hospital readmissions as either a 1 for no hospital readmission occurring 0 to 60 days post-discharge, a 2 for hospital readmission occurring 0 to 30 days post-discharge, or a 3 for a hospital readmission occurring 31 to 60 days post-discharge. No patient identifiers or EMR record data were extracted from the EMRs. The comparison of the readmission rates between the two groups recorded on the data collection sheets reflects not only the results, but the efficacy of the project. The list containing heart failure patients discharged from the hospital between January 1st, 2017 and December 31st, 2019 to receive usual care only was reviewed until 95 participants were obtained and recorded. The 0 to 30-day readmission rates for the 80 heart failure participants collected from the usual care plus telemonitoring group were compared to the 0 to 30-day readmission rates of the 95 heart failure participants from the usual care only group for data analysis. The 31 to 60-day hospital admission rates post-hospital discharge were also compared between the usual care plus telemonitoring group and the usual care only groups. The archive power of the 0 to 30-day comparison portion of the study was 80%, which is considered high. The archive power of the 31 to 60-day comparison portion of the study was 98.5%, which is also considered high. For the study, lower-tail z-tests for the difference of two proportions were utilized to determine the significance of the differences in the readmission rates between the control group and the intervention group. Two separate z-tests were used to compare the nominal data between the two groups. One z-test was used to compare the readmissions occurring 0 to 30 days post-hospital discharge, and one z-test was used for the 31 to 60-day post-hospital discharge comparison. They were both used to compare not only their readmission rates, but to determine if telemonitoring patients were retaining the information received while in the telemonitoring program and faring better after 30 days post-discharge than the patients receiving usual care only. Results. For the 0 to 30-day readmission comparison, there were 80 telemonitoring plus usual care participants with 8 actual readmissions, and 95 usual care only participants with 23 readmissions. This equates to a proportion of 10% for the telemonitoring plus usual care readmissions and a proportion of 24% for the usual care only readmissions. The same participants' 31 to 60-day readmission rate comparison yielded 10 readmissions in the telemonitoring plus usual care group and 35 readmissions in the usual care only group. This equates to a 12.5% readmission rate for the telemonitoring plus usual care group and a 36.8% readmission rate for the usual care only group. Here are the graphs of readmission rates between the two groups in percentages. Results continued. The control group who received usual care only had statistically higher readmission rates for the 0 to 30-day post-discharge period than the participants in the intervention group who received telemonitoring plus usual care. That is, P equals 0.0071. The control group, which included participants who had received usual care only during the 31 to 60-day post-hospital discharge period, showed statistically higher readmission rates than the intervention group with the participants who had received telemonitoring plus usual care. That is, P equals 0.0001. Protection of human subjects. There were no anticipated risks to the subjects in this retrospective chart review beyond the minimal risk of confidentiality breach. While there were no direct benefits to the patients at the large Midwestern healthcare organization during the study, the project can benefit patients treated at the same facility in the future. To minimize the risk of the breach of confidentiality, the researcher took the utmost care to protect data abstracted from the EMRs. All potential patient identifiers were removed. As mentioned, each EMR was instead assigned a number on the data collection sheets. The abstracted data was recorded using a code to represent the chosen variables, ranges, and constituted the minimum necessary data to accomplish the project's goals. The data collection sheets and the written lists were stored on a password-protected computer located in the researcher's locked office, which the researcher could only access during the data collection period. At the completion of the data collection, the researcher returned the written list to the regional analyst at the study site to be destroyed. No consent was needed for this project as it was a retrospective chart review. All collected data for the project will be destroyed 3 years after the completion of the project. Discussion, strengths. One strength of this study that it was adequately powered for both the 0 to 30 day and the 31 to 60 day comparisons. Past studies regarding telemonitoring in heart failure patients had been underpowered, which may have been why no statistically significant results were found. This study also utilized a control group for both data collection points. It was noted in the literature review that one study produced statistically significant evidence in favor of telemonitoring did not incorporate a control group. Another notable strength of this project was that no conflict of interest was apparent in the study, as the researcher was not employed within the department where the study occurred. Additional strengths of the study included utilizing a quantitative study design, being conducted at a large hospital located in a metropolitan area, and utilizing a retrospective chart review of electronic medical records. Limitations. For the more accurate interpretation of the study's results, it is essential to note that generalizability was not accomplished as this study was completed at one hospital. However, one of the goals of the study was to evaluate the effectiveness of the study site's telemonitoring department in the care of heart failure patients, as it had never been completed. The execution of the study allowed the researcher to accomplish this goal. Another factor that led to the decreased generalizability of the study was the exclusion of descriptive statistics. Many similar studies that included the use of descriptive statistics have been completed regarding telemonitoring in heart failure patients. Therefore, the researcher decided the use of descriptive statistics would not be used or needed. The use of a convenient sample may have resulted in the possibility of selection bias. Also, due to the hospital's lack of computer connectivity with other healthcare organizations, it was unclear if participants had been admitted to the hospitals outside of the study site area. There was no feasible way to discern whether an admission of this type had occurred. One exclusion criterion for the study included being admitted into a home health care program for post-hospital care. The participants' EMRs only reflected admissions into the study site's home health care program. However, the researcher took steps to minimize this limitation by searching each participant's discharge note for an admission order into a home health care program. Another limitation of the study included using the z-test of 2 proportions for analysis to compare the hospital admission rates between the 2 groups. It is possible that other statistical testing could have produced more precise results. Interpretation. It is important to note that the classification of patients' heart failure was not considered during the study, as it was not reflected in the EMRs. The size of change observed regarding hospital admission rates may have been affected, or may have affected the differences, or may have been affected by the differences in heart failure classifications between the 2 groups. Future studies should consider these classifications to minimize the differences among the intervention group and the control group, as it may lead to more significant outcomes. Here's a description of the heart failure classes. Hospital readmission rates are not the only way to measure healthcare outcomes for heart failure patients. Prior studies on telemonitoring included measuring mortality rates and quality of life scores. These measurements should be considered when future evaluations are undertaken to ensure a more precise reflection of the role that telemonitoring plays in healthcare outcomes for heart failure patients. Future studies should include other telemonitoring programs within the organization. Also, more extensive studies evaluating telemonitoring need to be conducted using the prior mentioned combined measurements of hospital readmission rates, quality of life scores, and mortality rates. The current guidelines do not require the offering of telemonitoring for patients regarding the treatment of heart failure post-hospital discharge. The findings of the study call for the policy of offering telemonitoring as a standard service for all patients discharged from the hospital for the treatment of heart failure. This implementation will allow for the overall reduction of costs associated with hospital readmissions and improve safety and quality of care. Currently, certain insurance companies may not fully reimburse healthcare organizations for the provision of telemonitoring to patients. Therefore, the hospital where the study occurred currently relies upon grant funding. This study's findings can also aid state and federal legislators in the act of allocating more significant sums regarding grant funding. Furthermore, state and federal legislators can utilize the study's findings to legislate for the better reimbursement of telemonitoring services from insurance companies. Recommendations and conclusions. The evidence found during the study indicates that telemonitoring plus usual care is an effective means for improving healthcare outcomes for heart failure patients, as reflected in hospital readmission rates. The results of the study should be shared with management at the study site, as well as other healthcare organizations that provide care to heart failure patients to facilitate the revision of their policies regarding telemonitoring. Sustainability. This project's results can be utilized at any healthcare facility with a telemonitoring department. The project can also be repeated in similar settings as this project's study site. The sustainability of this project's results is also significant given the recent healthcare changes due to the COVID-19 pandemic. Telemonitoring has become a widely utilized manner to monitor COVID-19 stricken patients from home and decrease the utilization of healthcare resources. Regarding heart failure patients, this study provided evidence that telemonitoring can lower hospital readmission rates. Furthermore, telemonitoring may minimize the transmission risk of COVID-19 to the already vulnerable heart failure population. Thank you for watching. Here are my references.